Thank you, Kate. Great talk. And now we're going to hear from Lee Jennings. Lee is Associate Professor and Chief of the Division of Geriatric Medicine at the University of Oklahoma Health Sciences Center. She's also the Director of the Geriatric Workforce Enhancement Program there. But I knew her when she was a fellow and then an early stage career faculty member at UCLA, where she was a key investigator on the UCLA Dementia Care Program, and she's remained very much involved in that program and highly productive in getting the word out about their results. So she's going to tell us about the UCLA model. Thank you, Lee.
Thank you, Josh. Okay, fantastic. I was making sure all of that slides were getting up there. So thank you first for the opportunity to be here today to talk to you guys. I'm very excited about it. We have been part of, as Josh mentioned, the UCLA Alzheimer's and Dementia Care Program for going on 10 years now, which feels a little crazy to say, and very excited to get to talk to you about the model and some of the outcomes, and then some of the work that we're doing to try to spread, as Dr. Poseen mentioned, really important now to be thinking about how we move this out of research and out into community care. So I have no conflicts related to this talk. And here's what we're going to cover today. So we're going to talk about, so Dr. Poseen mentioned sort of collaborative care or comprehensive care for dementia. There's some common elements across these different models. We'll talk a little bit about what those look like. We'll talk about the ADC program as a specific example of that, kind of what our outcomes have been to date with regard to care experience and quality for people living with the disease and their care partners, some outcomes that we've been able to improve for those individuals, and then also a little bit about utilization and cost. And then lastly, I think some of the most exciting work is some of the grant-funded work we've been doing on trying to really disseminate the program. So you've heard about care ecosystem, and you're going to hear about the ADC program, but there's actually about 6 or so different models of comprehensive or collaborative care for dementia, and they all actually look pretty similar. These are some components that have been identified by others about common elements of these programs. So they're all longitudinal, right? This is not a diagnose and adios model, right? This follows people from diagnosis of the disease through the course of the illness and until death. And it is really individualized, right? So it's what does the dyad bring to the table in terms of unmet needs and also strengthen resources, and how do we capitalize those and use those to help provide the very best care for that individual and their care partner. All of the models focus on psychosocial interventions, and this is again dyadic, right? This is a disease that is a journey for the individual living with dementia as well as their family or friend caregivers. There's also a component of self-management, right? All chronic diseases have components of self-management, and dementia is really no different in that it's about educating individuals living with the disease and caregivers about what is to come, what is some anticipatory guidance around complications we expect, how do we manage expected complications, behavioral, neuropsychiatric symptoms, how do we seek out and find resources in the community to help. So that's all training and education that's an important part of these models. Many of the models also address medication management, right? How do we interface with the healthcare system and advocate for what we need as patients and caregivers? Not all the models do this, but all of the models kind of bridge that gap between health system and community care for individuals living with dementia and their care partners. The particular listing also includes treatment of related conditions. For many people, Alzheimer's disease occurs later in life. And so we have comorbid, what I think of as geriatric syndromes, falls, mood disorders, swallowing complications, and recurrent pneumonias and emergency room visits for things like that. And so thinking through managing the related conditions and recognizing them as part of the dementia or how dementia affects the care of all other conditions is really key. And then lastly, coordination of care. So we think in healthcare a lot about coordination of care as traversing from the hospital to home or nursing home and home, but it's also, I think, transitions of care around transitioning between community resources and healthcare resources. And it's also potentially transitions of care related to living environment, right? So sometimes people are able to remain at home and sometimes they're not. And that's a transition for individuals, and these programs are all designed to think through that. And so again, these are the examples of some of the programs that kind of meet all of those components of comprehensive or collaborative care. Some are based more in the community with lay or non-licensed staff, and some are really much more focused as a clinical model within a healthcare system. But again, they all traverse. And I think more and more we're seeing actually much more overlap between community care and health system care. And this dichotomy really probably is not so rigid. And they all have evidence. So again, they're all better than kind of what we're doing in large part now. They all have evidence around supporting or improving outcomes for persons with the disease and also care partners, and some have evidence around improving unnecessary or reducing unnecessary acute care utilization and costs. So really, and many of them have actually had clinical trial data as well to support the model. So I think, as Dr. Postin pointed out, we're ready. We're ready to see these move forward, and the ADC is one model, but they all have different strengths, and they all have areas that may work better for one type of healthcare system or one type of community organization. So now I want to transition and talk about the ADC program. So the ADC program's mission is to partner with families, physicians, community organizations to maximize the individual with dementia's function, independence, and dignity while minimizing caregiver strain and burnout. That's always been our mission, and I think all of these programs have a similar mission. So let me tell you a little bit about the ADC story. So we're a health system-based model, so we function in an outpatient clinic setting. We began in 2011 with a philanthropic donation with a plan for 250 patients. Then we were lucky enough to receive a CMS Innovation Center Award in July of 2012 that allowed us to expand to over 1,000 patients. The program has continued at UCLA since that time through a combination of support from billing revenue, also institutional support, and also philanthropic funds. So it has taken a lot of different sources to try to maintain this program. And there's been over 3,500 patients that have been seen at UCLA as part of this program. We have 3 current dementia care managers and an active panel of 760 patients, and we have a wait list of almost 340 patients. So the ADC program, again, it's really designed to approach the patient and the care partner as a dyad. Both need support. This is a long care journey. And it uses a co-management model, which means that patients continue to follow with their primary care provider while also being seen in the program. We have an advanced practice provider that is really the linchpin of our program. We call that role a dementia care specialist. And the idea is to provide comprehensive dementia care with all of those elements we just described that's based in the healthcare system but really bridges into the community as well. So what's the process? How does an individual come into the ADC program at UCLA? So we do require, it's a health system-based model, we do require a physician referral. It can be from a primary care, it could be from specialty care, and the individual coming does need a diagnosis of dementia. So this has been thorny as we have implemented this at other sites because many people have cognitive impairment and don't have a clear diagnosis, right? So many of the sites, including UCLA, have actually implemented a separate memory evaluation clinic in order to provide that resource, help patients obtain a diagnosis, and then, if appropriate, come over into the program. And also, our model focuses on people that are community dwelling with dementia. And part of this is because we don't have a nursing home care model. So if someone is already living in a nursing home, the model is really less impactful with what we can do to change outcomes. After the referral process, then there's an initial assessment individualized with the person with dementia and their care partner, 90 minutes. So you get a long visit. I don't think many people get 90-minute physician visits or provider visits, but it's really needed. And the idea is to come out of that visit understanding what are the needs and what are the resources of the dyad and creating an individualized dementia care plan. That care plan then is monitored and revised as needed over time. Is it actually achieving what we had intended to achieve? Have things changed over time and it needs to be revised? The program also provides 24/7, 365 telephone access to the program for patients at home. Emergencies don't always happen during office hours. A key part of preventing unnecessary urgent care or emergency room visit is access. And then we have a follow-up, a telephone follow-up protocol that is based on acuity. And so we use a red light, yellow light, green light system to triage dyads based on either patient needs or symptoms or caregiver strain or recent acute care use. And those patients that are red get closer follow-up. So they could be called anywhere from every 1 to 4 weeks, whereas patients that are yellow are called every couple of months, and then the green patients are called every 3 months. So similar to the care ecosystem model, we're always available for follow-up, but there is a proactive component to outreach so that we can catch problems early. We do have an in-person option for people to come in and be seen, but at the minimum, they need to be seen at least once in person annually. There's also a referral component, so this is, again, referral to community resources and then specialty care as needed for the individual. Partnering with community-based organizations is super key to the ADC, I think, working well. That includes, and these are the 6 programs, 6 community organizations for which the ADC is currently partnered. And when we actually had our initial CMI grant, we actually paid the community organizations to provide services because it was such an important piece of getting their partnership, and that their services are not free. They have staff. They have to cover those resources, and that's not something that's covered, by Medicare billing. So trying to have a financial, relationship is just as important as a partnership. So we have services for patients, we have services for caregivers and families, and then we also implemented a voucher system. So often you'll recommend services, and there's some resistance to being able to actually go and use that. It's inconvenient. What am I going to do with my person with dementia if I need to go in and get a service? And so forth. And so what we did was create a voucher system so that there was an opportunity to kind of decrease the cost to the individual so that they could try out that service, see if it fit, see if it was a good fit for them, and that's helped encourage patients to and caregivers to use those services. And then the linchpin of our program, the dementia care specialist. So this is an advanced practice provider, nurse practitioner, clinical nurse specialist with prescribing authority or a physician assistant. The panel is about 250 patients. Again, it's a co-management model. There is an extensive online curriculum that's available through the Gerontological Advanced Practice Nurses Association. Eat your Wheaties. It's like 22 modules and 4 videos. It is available without adopting the model, but I will say that I think that skill training alone, while valuable, is not the same as the training that is needed to actually implement the entire model. And then I also want to talk about a dementia care assistant. So after we launched the model, we realized we really needed some additional workforce here. And at UCLA, this is a non-licensed trained staff. We've had other dissemination sites use nurse care managers or social workers, but the idea here is, again, to help the DCS work at the top of their license, outreach to lower acuity dyads, do that telephone follow-up, and identify people with needs early in a proactive way. So I'm going to switch and talk a little bit about some of our outcomes to date. So we've had almost 300 physicians refer to the program at UCLA, and the vast majority have found it really valuable. They've said we've had valuable medical recommendations, behavioral recommendations. It's actually enhanced their relationship with their patient, saved them time, and they largely would recommend it for others. And I think this is important because I think there is a gap, a quality of care gap in primary care for dementia. And I think these models, if we're able to get them out, offer primary care providers a place to send patients when they're not sure what to do next. So it's a really important resource for people, for providers in addition to patients and caregivers. When we started off, we wanted to look at the quality of care that the program was providing, and what we found is that we really met all of the quality indicators for dementia. These are based on 15 quality indicators. And I just put up some comparison numbers. So if you look at primary care alone, it's just under 40% of recommended care for dementia is received. If you do co-management with a nurse practitioner, it's 60%. And if you implement a comprehensive care model, you really start to see a move toward higher quality care. These are some outcomes. This program was implemented as a clinical program. It was not evaluated. It was not a trial. So these are baseline and 1-year data. And again, this program doesn't stop the advance of the disease. So we saw worsening cognition and function, but we also saw an improvement in behavioral symptoms and a decrease in caregiver strain. And then lastly, for our utilization and cost outcomes, so this was a series of 3 studies that we did looking at ADC patients as compared to propensity matched. So we took patients from claims data and tried to match them as close as we could to our cohort. And what we found is that the program reduced ED visits, it reduced length of hospital stay, so it didn't reduce hospitalizations, but if you were in the hospital, you stayed there fewer days. It reduced long-term care nursing home placement. And then it increased the use of hospice in the last 6 months. So in the United States, most people with dementia die in nursing homes. And in this program, they died at home on hospice. So what are we doing now with regard to dissemination? So I think there's 2 exciting initiatives. One is the DCARE trial, or Dementia Care trial. It's a PCORI and NIA-funded pragmatic trial, 18 months, 4 sites nationally. There's an intervention arm that is the ADC program. It's a comparative effectiveness trial. The other arm is the BRI Care, or Benjamin Rose Institute. It's a community-based model. And the third arm is usual care. We just finished enrollment for this trial in January, and so more to come. So that's kind of an exciting opportunity to advance the science of these models. And then I'm going to spend the rest of the time talking about our John A. Hartford-funded dissemination. So this is our process for dissemination, and this is kind of over the last 3 years, so 2019 to 2021, what we were able to accomplish with regard to dissemination. So we had 80 sites that initially expressed interest. Then sites that were followed up with us then had an initial phone call, explain the program, talk through whether it was a good qualitative fit for their health system. We had, from those calls, we then had 23 sites complete a readiness assessment, which goes through what are they hoping to accomplish, what resources do they already have, what would they need to, what staff would they need to hire to be able to implement. And then there's also a business case call. So we've built a tool that sites can use to help them understand what their potential billing revenue versus costs would be. That's a really important piece for health systems to want to understand to implement. And then 14 letters of agreement. And what you see here are the sites where we have disseminated the ADC program to date. The purple sites are the clinical trial sites, and the red sites are the Hartford-supported dissemination sites. We learned a lot in this process. It has been, I just want to point out this was also done during COVID, so it was challenging, and I think slower. You always want to do things, you always were excited about it, you want to get it out there, but, don't underestimate the time that is needed for program implementation, and these were some lessons learned. And I think these are largely lessons that if you've tried to implement will resonate. So having a product champion, you've got to have somebody within the health system that is a champion for this. The business case is critical, sort of talking through what does this mean financially for the institution. Training, right? Not just training of the advanced practice provider, but training in the model. Local factors are important. Where can you adapt? Where do you need to have adaptations of the model versus what are the pillars that really need to stand to achieve the care outcomes you're wanting? And then again, patience and time. So what's coming new in 2022? So we received a second grant from the Hartford Foundation to establish an ADC dissemination center. Please check us out. That's our website. And we obviously have the goal of trying to disseminate the ADC program, but we also want to offer a menu of options because we recognize that this may not be the right model for every healthcare system. So we have information about other models of care, about training in general for dementia. We also have a national dementia care learning collaborative. So this is an ongoing community of practice for sites that are adopting as well as sites that are considering adoption. We have our first meeting actually on Tuesday, so it's exciting. We're also partnered with the Institute for Healthcare Improvement for their age-friendly health systems work. So there's about 2,800 health systems nationally that have now been recognized as age-friendly. Age-friendly is, I'd like to think of it as geriatrics in a nutshell. So it manages mobility, medications, mentation, and what matters most. And so for all the sites that are implementing ADC, they'll also be recognized as age-friendly. We have a ADC program, Project ECHO. So Project ECHO is the concept behind ECHO is to move knowledge, not people. So it uses televideo conferencing like Zoom to provide access to experts in dementia care with a short didactic, but really a focus on case-based presentations that clinical providers or community professionals may have in their interactions with patients and clients. And then lastly, with our new grant, because we do have many more sites that we're hoping to disseminate to, there is a cost share. So here are our big, hairy, audacious goals for the future. With this new grant, our goal is to try to disseminate ADC to 50 additional sites nationwide. We hope that then tens of thousands of people with dementia will receive ADC care, and ultimately we want to try to influence policy and move the needle so that we have payment models that will work to disseminate these comprehensive care models for dementia, not just for the ADC, but for many of them that have good evidence base. And with that, I would like to acknowledge our amazing project team led by Dr. David Rubin at UCLA. Thank you.
Yeah, please. Great. That was excellent. I'm going to invite Dr. Posehn back up. I agree they share a mission, and I'm going to ask them to share a microphone as well. We had one, we're up to 2 in the chat, and we're going to take questions from the audience as well. We'll start with the chat. So great talks, great programs, very exciting. How can family caregivers talk to their doctors about getting that first step? And I know it's not directly related to the programs, but getting that diagnosis in the first place so that they qualify for fantastic programs like yours. And I just want to let the audience hear your insights on that.
Yeah, I love that question. The other half of the work I do, which I didn't talk about today, is about improving diagnosis starting in primary care. And so what I would encourage family members and people to do, if they have a concern that something is different, to voice that strongly to their primary care provider. And if their primary care provider says, oh, don't worry, it's, people forget things as they get older, but if you think there's something wrong, you need to really push. Unfortunately, that's what it takes oftentimes, is it takes families and people with these symptoms themselves to push to get that diagnosis and to get linked to better care.
Yeah, I would echo that. And I would say part of what we need to move these models forward is consumer demand. So if the clinicians, all of the product champions at these sites we disseminated to have been clinicians who have been frustrated with the current care. And so, we need your voice to come forward and say, no, there's something wrong here. We need a diagnosis and we need a plan.
Another really important question, how do your programs, can your programs be modified to serve patients who live alone?
Absolutely. So it is not a requirement that you have a care partner to be, and I don't think in any of the programs. We do try to help individuals find a network of resources, including human informal caregiver resources or friends or other ways, but absolutely it's not a barrier.
So I think, Lee, you mentioned the wait list. Kate, is there a wait list for the Care Navigator program? I think, the question is, how do we not have wait lists? It's a big question. It's perhaps beyond our scope for today. I think we all agree that we want people to have access to the resources we so desperately want to provide them, but any thoughts on how we do that?
There's a lot more demand than there is access to these services, unfortunately. And so what I know both Lee and I are working on a lot is thinking about what are the business models? How can this be financially sustained in different types of health systems? For example, utilizing billing codes that exist but maybe aren't being used enough, but could be used to help pay for this. And also trying to show value to health systems. Some health systems are what we call value-based, and they actually are incentivized if they can prevent patients using unnecessary emergency room hospitalizations. They save money. And so that is another way that we can sell it to health systems. And then lastly, with work pioneered by the Alzheimer's Association, and David Rubin was part of this, but there is a new payment model that's being considered by Congress right now to help pay for this type of care. So from the main thing I'm thinking about to answer that question is, how can we show health systems that this is financially sustainable so that they can provide it at a greater scale?
I think that's so critical. One of the things we saw when we did this model at UCLA is we actually, in one of our studies, saved Medicare about $2,400 per patient per year. But UCLA didn't see any of those benefits. So the institution came back and said, well, it's fine that you're saving Medicare money, but it's still costing us money to run the program. So we need payment models that align the incentives so that people have better access and that these are possible for healthcare systems to really to sustain over the long term.
And does either program prioritize patients in greatest need in any way, or is it kind of a one-size-fits-all wait list?
Yeah, we are if different health systems that are doing the care ecosystem are applying it in different ways, but I would say in general we do tend to prioritize families that have greater needs, that are in more of a state of crisis, who need the help the most. But frankly, I think all families living with dementia can benefit from this type of program.
We try to take them in order, because everybody, all of those patients want access to the program. But we try to provide kind of curbside consults, e-consults, to primary care, so that we aren't leaving people without help.
And last, at least for now in the chat, collaborations in other countries.
Just starting some of this work. Just submitted a grant last month to do this in Ethiopia. And there's a grant under review to do this in Belgium, but just starting. But the thing is even within the US, every health system seems to have a different business model and different incentives. It's so hard to do it here. And then moving into other countries, just trying to wrap your brain around it. Oh, we have a project that might be going on in Peru as well. But it's like a full-time job just to try to do this in any one country. But I am starting to consult on projects in other countries.
Wonderful. Any other questions from the audience? I think I got one more in the chat. I'd be remiss if I didn't say that there's also very exciting work happening here at UC Irvine with Dr. Lisa Gibbs, Dr. Steve Tam, and others in the Division of Geriatrics here around caregiver education and caregiving models, supportive care models. I can't talk and read at the same time. Every Alzheimer's patient's journey is different, agreed. I think we heard a little bit about this, but I'll let you follow up around specifically agitation and aggressive behaviors and how these programs help that, along with medications. Dr. Postina, I remember you had a bit on your slides about inappropriate medications, but any comments you guys want to make about these obviously very challenging aspects of the dementia caregiving journey?
I think it's a critical part of the training for our advanced practice providers is around understanding themselves, best practices for behavioral management, and then also understanding how to teach it to others, to be able to give people skills that they need to manage behavioral symptoms when they occur.
Yeah, we use something called the DICE model, and our nurses would be able to describe this much better. But basically, our navigators are working with the caregiver to really understand what the behavior is, when it happens, what the triggers might be. So the care team navigator works with the caregiver to try to investigate what's causing this behavior, what's the underlying feeling or situation that might be contributing to the behavior, and then thinking about strategies to try to modify that. And our navigators frequently spend time consulting with the nurse supervisors around these different strategies, and we just try different things and see if anything will work. And we if absolutely necessary, then consider pharmacological approaches.
My thanks to people online. We're going to take one last question here live in the audience.
Okay. Okay. My question is, do you foresee in the future that we will be able to get the Public Health Department, Medicare, insurance companies like Kaiser, and home health agencies to be involved with this? And what about the cost involved for the individual? Is that clear?
Yeah.
Yeah, so the out-of-pocket costs, I mean, as you all know, are substantial. And we did see it in the program implementation as a barrier to using some community services. And so that's part of the reason that we worked with some people that wanted to donate at UCLA to actually focus on a voucher system to try to reduce that cost burden. That doesn't cover anywhere near the total cost out-of-pocket for individuals, but I think it's important to recognize as a program that that is a barrier.
But are your programs charging people to be?
No.
I think that's what the question
Sorry,
was, and I want to
missed
make
it.
sure that
I missed it.
Yeah.
Thank you for that. Yeah, I missed it.
Of course not.
No, yeah, no. There's no. Our health system model. So we do bill insurance, we bill Medicare for the visit, but there's a copay to the individual, just like there would be for any other visit based on their insurance. But there is not like a membership fee or additional fee to be part of the program.
Great. I think that was fantastic. I'm sure my audience wants to join me in thanking you both for this fantastic presentation.